The myocardium itself is the innocent bystander in most heart diseases. The primary problem is really in the blood vessel. The major blood vessel disease, atherosclerosis, is usually caused by an excess of risk factors such as high levels of low-density lipoprotein, LDL, depicted here by the yellow spheres. Of course, there are many cases of atherosclerosis when cholesterol is in the average range, and we're learning a great deal about non-traditional risk factors, but let's consider the case of low-density lipoprotein, which when persistent in its excess, can accumulate in the artery wall and become modified by oxidation, shown by the brown color. That can inflame the endothelial cells, which will express adhesion molecules for leukocytes, or inflammatory white cells, which will then penetrate into the intima, where they'll take up some of the lipoprotein particles and transform into foam cells, the hallmark of the fatty streak, the early atherosclerotic lesion, which usually grows in an outward direction. Lesion complication begins when the smooth muscle cells in the intima begin to divide and secrete extracellular matrix molecules, such as collagen. Other smooth muscle cells will penetrate into the intima from the media, where they will join the other smooth muscle cells in forming a fibrous cap overlying the lipid core. When there is a persistence of risk factors such as high levels of LDL, the lipid core grows and it sets off an inflammatory response. Leukocytes, such as the T lymphocyte, can send signals to the macrophage, either soluble signals, or it can activate the macrophage by contact. The activated macrophage can then secrete various mediators, including matrix metalloproteinases, which are enzymes that can weaken the collagen in the plaque's fibrous cap, making it susceptible to rupture. When there's a rupture of the plaque's fibrous cap, it can cause a thrombus, which when sustained and occlusive, can cause an acute myocardial infarction, shown by the ST segment elevation. However, we now know that most plaque disruptions are actually clinically silent, or when subtotal or transient, can cause an episode of unstable angina, shown by the ST segment depression. But when that clot resorbs, it can cause a healing response that thickens the fibrous cap and narrows the lumen, giving you a stable but symptomatic plaque. When we intervene to lower the risk factors such as low-density lipoprotein, it gives a chance for the lipid to leave the plaque's central core and allows the inflammatory white cells to depart or die by apoptosis. That gives a thickened fibrous cap and an uncompromised lumen, which will yield a stable and asymptomatic plaque.
The heart muscle itself gets its oxygen supply from the coronary arteries. When blood flow within a given artery is obstructed, the heart muscle normally fed by that vessel can begin to die. The initial lack of oxygen is called ischemia. If allowed to continue, it causes injury to the myocardium. If untreated, the tissues eventually die completely, a condition called infarction. The effects of ischemia appear on the EKG as changes in Q waves, ST segments, and T waves. ST segment, depression, elevation. T wave, peaking, flattening, inversion. Q wave, deepening and widening of Q waves. Loss of R wave resulting in deep QS wave. These ischemic changes are indicative of myocardial damage. They can be found alone or more commonly in combination with one another to produce a variety of patterns.
Coronary artery disease is a disease in which your coronary arteries are clogged by fatty deposits known as plaque. Your coronary arteries are the major blood vessels that supply your heart with blood, oxygen, and nutrients. If the buildup of plaque occurs in one or more of your coronary arteries, a heart attack may result. This can also lead to angina or a chest pain caused by insufficient blood flow to the heart due to atherosclerosis or the accumulation of fat-containing deposits on your artery walls. Here's a picture of the right coronary artery. The yellow stuff you see is the plaque, and the plaque is what blocks the flow of blood to the heart, resulting in a heart attack. The plaque may break or rupture, causing a clot to form and blocking the flow of blood to the heart. In this case, you may experience angina or chest pain caused by insufficient blood flow to the heart, and you must seek medical attention. Symptoms may include sweating, shortness of breath, pain that spreads from the chest to the neck, the jaw, or one or both shoulders or arms, dizziness or lightheadedness, a fast or regular heartbeat, or a loss of consciousness. If you experience one or more of these symptoms, seek medical attention. When you arrive at the hospital, you will be given a sedative. Then you will go through a procedure known as angioplasty. During the procedure, a long thin catheter is inserted through an artery in the groin or arm, and then into the narrowed coronary artery. Then a wire with a deflated balloon is passed through the catheter into the narrowed coronary artery. The balloon is then inflated, and the pressure from the balloon presses the plaque against the wall of the artery to make more space for blood to flow. A stent is then left in the artery to help keep the artery open so blood can flow into the heart. The stent will also prevent small pieces of plaque from breaking off, which may cause a heart attack. Angioplasty procedures may last for about 1.5 to 2 hours. The average hospital stay is 1 to 2 days. After angioplasty, you will take antiplatelet medications in order to prevent another heart attack or stroke. If the affected coronary artery during angioplasty cannot be reached, you may need coronary artery bypass surgery. During the surgery, the surgeon makes another path for blood to flow into the heart by taking a vein from another part of the body, such as the chest or leg, and grafting it onto the heart, so blood can take a new path to flow into the heart.